So this next screencast is going to focus on lipids, but is also going to kind of pull together some of the other risk factors. And this diagram gives you an idea of how they all link together. And what you'll find is over the next few weeks that you'll be able to build the links between obesity, diabetes, high blood pressure, high cholesterol, and overall cardiovascular disease risk. So obesity we talked about last week. Diabetes we'll talk about next week, or type 2 diabetes next week, and we will talk a bit about high blood pressure and lipids in this week's session. So what you've got here is there's just kind of link of all of these things together, and we're going to focus, as I say, about lipids for this particular part, but all of them are linking, so I may repeat myself over the next few weeks because there is so many links between all of these different aspects. So what are we talking about with lipids? We are talking about fats that can be liquid or can be solid. And for the focus of cardiovascular disease, we're talking about lipoproteins, which are protein molecules that carry lipids around the bloodstream. So they're made up of fat, which is mostly in the form of triglycerides, but cholesterol as well, and protein. And historically they've always been classified by their density. So high density lipoproteins are smaller. So that's the kind of way that they've always been classified. What we know is that different lipoproteins have different impacts on our cardiovascular health. So low density lipoproteins are the ones that have historically been seen as bad. And they carry cholesterol around the body, but they tend to be a bit sticky. So they are ones that stick to the walls of blood vessels and therefore narrow them and sometimes cause blockages. And this is the process of atherosclerosis. So there's a little video clip here that's less than 2 minutes, but it perhaps explains that better than I can. Gives you an idea of how LDL tends to lead to atherosclerosis. The high-density lipoproteins, the HDL, have the opposite effect. They take cholesterol from the body back to the liver so it can be broken down and excreted. They're produced by the liver, so from within the liver, and they have an anti-inflammatory effect. So LDL is inflammatory, HDL is anti-inflammatory, and therefore protects against atherosclerosis. And they have a number of effects. They make the membranes less sticky. They tend to lessen the plaque buildup, and they carry an enzyme that prevents the LDLs from becoming inflammatory. So they're having the opposite effect. So what that means is, in reality, we're really interested in the proportions of the two, the ratio of LDL to HDL. It's really important, not just the total amount of cholesterol. So for years, it was just total cholesterol that was measured, and now we know there's actually profound differences in the way that different lipoproteins react and the risk that they, or protective factors that they have. Cholesterol is highly influenced by genes, as well as lifestyle factors like diet, smoking, high alcohol consumption, and physical inactivity or activity levels. So we know that all of those things will influence it, but some people will never be able to overcome the fact of the genes making them more likely to produce LDL. This diagram is here just to kind of give you a bit of an understanding, I guess, of the different cells that are working. It's not a simple process, atherosclerosis, and these endothelial progenitor cells are the ones that help to regenerate the lining of our blood vessels. So they're really important cells that are coming from, influenced by the HDL molecules. So there's lots of different cells doing lots of different things in our blood vessels. The other fats that we have are triglycerides. So these are the most common ones, although we don't tend to hear them talked about quite so much. And if you've got somebody with high triglyceride levels, it could be genetic, But what you'd be looking at as a dietitian is, are they having high levels of simple sugars, refined carbohydrates, or alcohol? So somebody on a high sugar diet or high alcohol consumption is very likely that they will have higher levels of triglycerides. So that's something that you'd be looking for specifically, just to see if that's impacting on triglyceride levels. So blood lipids are measured with blood tests, and these are very commonly done. And there's been debate over decades now. Do increased blood cholesterol levels really increase the cardiovascular risk? And if they do, how does it happen? This analogy may help you. Thinking of arteries as roads, the lipoproteins carrying cholesterol as cars, and the cholesterol as passengers. So you've got that different density of lipoprotein relating to how many passengers are in the car. And what we're looking at now, rather than just looking at total cholesterol, which measures the number of passengers, but we are now also know it's how many lipoprotein molecules are out there as well, which increase the cardiovascular disease risk. And what we're particularly interested in now is those molecules that are not HDL. And all of those are seen as the more problematic, having a more negative effect. So we now look at total cholesterol and we look at HDL, and therefore from that calculate non-HDL. So a full lipid profile will give you all of these different components, which is really important. And just to give you an example here, so non-HDL is the difference between total and HDL. Simple maths. Total cholesterol 6, here's an example. If the HDL is 0.8, then the non-HDL is going to be the rest of it, is 5.2. So what we're aiming for is that the non-HDL should be less than 4 for the general population. But if someone's already got cardiovascular disease, or they're at a more than 10% risk of developing cardiovascular disease within the next 10 years, we're actually aiming for lower levels as a preventive measure. And the reason we use these non-HDL is because it's the best way of measuring all of the other things. It doesn't have to be a fasting lipid profile. It always used to be you had to have them fasting. It doesn't have to be. And non-HDL is still accurate when triglyceride levels are high, which measuring the individual component of LDL wasn't if triglyceride levels were high. So you had to make an adjustment for that. So what are we aiming for? So total cholesterol should be below 5. Non-HDL for the general population should be below 4. LDL below 3. The HDLs, we're looking for levels of more than 1. So that 0.8 that I showed you in the previous slide was too low. 1.2 for a woman. So slightly different a genetic picture there. And above 6, we're looking at the ratio. So the ratio of total cholesterol against HDL is really important. So it's not just the total amount, it's that ratio between the two. And if that ratio is above 6, then there's going to be a higher risk. So we want a lower ratio between the two of them. And the triglycerides, non-fasting, below 2.3 would be normal and considered healthy. So HDL doesn't have to be very high. It shouldn't really be more than 1.4, but it might be if there are other risk factors involved, such as excessive alcohol consumption. Some medications will influence it, some medical conditions will influence it. So as always, you're looking for a broader picture to understand these figures. And I just wanted to draw your attention to the effect of physical activity on lipids, because we tend to think of diet, but actually physical activity is really important as well. There's so many reasons for encouraging people to be physically active, and this is one of them. So we're encouraging people to be active because it reduces LDL and increases HDL. So it's helping us to get in that better balance, that better ratio. The recommendations for physical activity, whether you look at the UK recommendations or the WHO, they're very similar. We're looking at trying to avoid physical activity. Avoid sedentary behaviour. Don't avoid physical activity. We're looking at 2.5 to 5 hours of moderate physical activity per week. So that's 150 to 300 minutes. Or 1 to 2.5 hours of vigorous physical activity, or a combination of the two. These should be in at least 10-minute blocks. And we're looking at people being active, ideally, at least 5 days a week, so 4 to 5 days a week. So they can get those balance between the two, and remembering that, weight management requires more. And also, of course, if someone has had a coronary event, like a heart attack, then that they will be supported by physiotherapists to build up their physical activity again. So that is a different situation. So these people with myocardial infarction who have had coronary artery bypass grafts, those kinds of things, they will be advised differently. So it's not quite the same as the general population. But the key thing that we need to be mindful of is that physical activity has a positive impact on blood lipid profile by reducing LDL and increasing HDL. So in most cases, we're going to be encouraging physical activity to increase in most of our patients.